I'll just get a cup of glass of water and come. I'll be back in a minute. Ice. Somebody's disappeared.
Sabarishan.
Somebody shut disappeared. Yes.
So we'll start now.
Yeah, sure.
Good evening, one and all. We are gathered here for another exciting slide seminar. At least I know I'm really excited about it. So today's slide seminar is on surgical pathology, and it basically deals with problems with women. So it's an innovative name all about Eve. So we have none other than Dr. Anita Borges, who needs no introduction. She is a lab director, consultant pathologist in Center for Oncopathology. We have 4 residents on board with us, and I would request them to introduce themselves.
Good evening.
Yes.
Good evening, everyone. I am Shabri S. Krishnan G, third year postgraduate resident, RCC Trivandrum.
Good evening, everyone. I am Dr. Aman Thakur, PhD third year from BP Karal Institute of Health Sciences, Nepal.
Good evening, everybody. I am Dr. Qayyum, postgraduate second year from Government Medical College.
Good evening, everyone. Myself, Dr. Munish Kumar God, PG third year, SMS Medical College, Jaipur.
Dr. Munish?
Yes, ma'am.
He introduced himself.
So, I am Dr. Shweta. I am moderating this session. I'll be helping ma'am during the web slide seminar. So, mainly it is a different format. Instead of the conventional microscopic teaching, we are going to have a kind of approach-based teaching with Borges ma'am, and this is like the four different residents from different parts of the country as well as from Nepal. They are kind of representing different residents from different parts, and I will play a role of being a link between attendees and ma'am. So any kind of questions, anything that you would like to ask, please write in the chat section. I'll be passing your questions to ma'am. So in case of any audio or video failure, please click on the reconnect button. You can use this red button for viewing full screen. There are a few reminders that you can always do reconnect, use the reconnect button in case of any audio video failure. Please answer the questions asked in the poll section and not in the chat section, because your answer can be counted only if you answer in the poll section. So here are a few disclaimers. These are few other disclaimers. So with this, I would like to hand over the dais to ma'am, and I would request her to take the cases forward. I'll not act as barrier between you and ma'am, and so I request ma'am to please take over from me.
All right. Thank you very much, Shweta. It's been exciting actually interacting with postgraduates from all over the country, and I understand from other parts of this country as well. Today, we have four young men who are going to look at these slides, and all the slides are from, females and their problems. Now, I chose this title called All About Eve from this very famous, very old-time movie, which was made, I think in the 1930s. And I think those of you who are film buffs, it is a really, really very interesting movie. It was nominated for so many Academy Awards. It actually won Best Actress, Supporting Actress Award, and several other awards. It's about this this woman, and you see her on in the front of this picture. She's Betty Davis. None of you're just too young to have heard about Betty Davis, but in her day, she was an absolute sensation. She was a knockout. She was considered as one of the most beautiful women of her age, and she was really a fabulous actress. So she is playing the part of Eve. Eve is her name in this particular movie. And the movie is fascinating. It's about the rivalry between film stars, two women film stars, and how one tries to steal the roles from the other film star. So now this is all about Eve, and as I told you, I've adopted the title of my slide seminar from this. It is actually, who is Eve? And I'll tell you where this name comes from. Some of you might know it. Does anybody know from where this name Eve comes from? Anybody has heard? Kayum, you know where this name Eve comes from? No? Okay. Even in the Quran, you must have heard about Adam. Adam, you heard of Kayum? Yeah, who was Adam?
First prophet.
Yes, so he was the first prophet. He was, according to the Christian tradition, the first man on the earth was Adam. Yes, we call him Adam. And the first woman was called Eve. Okay, so this is a very, very old name. And it comes from this, the creation myth. And what is that creation myth? God said, let there be light. We lose a little bit of the top of this because of we are using the whiteboard. But God said, let there be light, and then day and night was created, and so on and so forth. And finally, on the sixth day, God is said to have said, let there be animals on the land, and man to lord over the beasts and fish and the fowl. And so the first man was created after all the animals were created. And this man we know as Adam. And what is very interesting in the Christian tradition is, and you see the picture that is over here, it's a very famous painting from which you see that Adam has been created and he's asleep. And you notice that Adam and Eve do not have any clothes because they roamed about like the other animals in this garden of paradise, which we call Eden, absolutely unashamedly naked. But what you see is that Adam came first, and from Adam's side, it is said from his rib, Eve was created. Okay? And then God was so tired, after 6 days of creation, he created the waters, he created the day, the night, he created heaven and earth, he created the fish and the birds and all the animals, and then of course he created man and woman, and on the seventh day he rested. And according to the Christian tradition, we work Monday to Saturday, and on the seventh day we have a holiday, like what God did. Now, we should ask a question. Okay, if you go through embryology, this is what the myth says, that man came first, and from man God created Eve. Now I want to ask this question. Who came first? Adam or Eve? Anybody wants to take a crack at that? You want to know, you want to ask? Yes, Shabri, do you think Adam came first and from Adam Eve was created?
Yes.
What do you think? Yes. Shabri thinks yes. What about you, Monish? What? Yes? He doesn't know because you haven't read the the scriptures. Okay, Monish, never mind. What about Aman? What do you think? Adam came first and then Eve came later?
I think Adam came first. Ma'am.
Adam came first. Very good. And what about you, Qayyum?
Adam came first, then the woman was created from the ribs of the.
Oh,
Adam.
okay. All right. Now, if you think so, then let's go through embryology, okay? If you have to answer that question, the answer is not Adam at all. It's Eve. Eve came first. And you can know this because females are considered to be the fundamental sex. When a fetus is developing in the womb, yeah, without chemical prompting, that means there have to be the right chemicals that are secreted at the right time. All fertilized eggs, irrespective of the chromosomal sex, whether you are XX or XY, would all develop into females. Just go and read your embryology and you will find that males have to work very hard to become males. So don't talk about Adam coming first and Eve coming from the rib of Adam, etc. They really have to work very hard to become males. Because if you go through embryology, and I think all of us should not leave embryology to when we were in the first MBBS and what a bore it is and all of that. As pathologists, you just have to go through some of what I have highlighted over there, and you will realize that there are many, many disorders that occur because the chemicals that are required to turn a fetus from a female into a male must be secreted at the right time. Okay, look at this SRY gene. It is the sex-determining region on the Y chromosome. First of all, you may have a Y chromosome, but it must be present. If the gene is lost on the Y chromosome or it is not turned on, you will not have a testes. Okay, so if you don't have a testes, then you're not a male. And this testes must secrete testosterone. The Leydig cells must form, and then the Leydig cells will turn the clitoris. And those of you who understand this embryological relationship, that you have gonads. The gonads are testes in males and ovaries in the female. And the female has a very small little structure which is called the clitoris, which enlarges under the influence of testosterone to become a penis. So if you don't have a testis, you don't have an SRY gene, you may have a testis, but there is no testosterone, that your external genitalia will not look like a male genitalia at all. Then is the famous Mullerian inhibiting substance. It is secreted by Sertoli cells. All right, so if the Sertoli cells are not there or they are unable to secrete the Mullerian inhibiting substance, the Mullerian system will develop. So you will have a very anomalous situation that you have the internal organs of both males and females, because the testosterone allows the Wolffian system to develop into the male genitalia, the male internal organs, but you don't have the inhibiting substance, and therefore the Mullerian system also coexists. And this is a form of, it's not a very common syndrome, but you do get both the male system as well as the female system lying there side by side as the internal organs. And finally, you get this very curious syndrome in which you have everything. but your end organs are insensitive to the testosterone. And therefore, there is a testes, there is testosterone, and yet this child looks like a female. And many of these individuals don't even know that they are not females, that they are males until they get married. And when they get married, and some of them are the most beautiful, well-developed females that you will ever find. And they have been brought up by their parents as females, but of course they don't get periods. Some of them, get married and then find out that the reason that they don't have, periods, etc., is because they are actually males. Okay, so the males have really to work very hard to become become into males. Now here you can't see the top of this screen, so maybe I'll just turn off the whiteboard for a minute. And this is a true story. All right. Here you have the anatomy practical soft part orals, and you see that this lady over here, yes, she's appearing for the orals, and you can see she's been asked by her examiner to pick up any soft part, and she has picked up. You can see what she has picked up. What has she picked up? The uterus. And she's looking at it this way, and it's a true story. Looking at this way, that way, every way. So the examiner said, "I will give you a hint." And he said, "Madam, I give you a hint. Something that you have, which I don't." And she thought for a minute, and then her eyes lit up. And you know what she said? She said, "Brains, sir." Now you're laughing, you think, what a silly woman. And but it is a true story. But when you think about it, the candidate was right. You know why the candidate was right? Because the majority of the genes for intelligence lie on the X chromosome. And how many X chromosomes do women have? Can you tell me, Monish? How many X chromosomes does a female have?
2.
2. So if the genes for intelligence lie on the X chromosome, then don't you think that females are doubly intelligent? Of course they are. Yeah, so don't tell me about Adam coming first and females and the female coming next. That's Eve. Also, many people don't realize that the mitochondria have genes. Do you know that there is DNA in the mitochondria? All of you know that. Very good. But where do we get our mitochondria from? Do we get it from our fathers, or do we get it from our mothers? Where do the mitochondria come from?
Maternal.
Sorry?
Maternal.
Yes, because why do you say it is maternal? Yes, Kayum, tell me, why do you say that the mitochondria come from the mother? You said no. You said it is maternal. So why? Why do the mitochondria come only from mother? Shabri, why do the mitochondrial genes come only, or the mitochondria themselves, and they have genes? Why do they come from the mother?
Because the mitochondria will be destroyed in the sperm during fertilization.
Oh, the mitochondria are destroyed in the sperm during fertilization. Do you agree with that, Monish? That somehow fertilization destroys the mitochondria. What do you think, Monish?
And I think mostly cytoplasm of ovum zygote is received from ovum.
Absolutely, Monish. Very good. See, you're very well versed in what happens amongst females. Okay, so when it's the ovum that has the large amount of cytoplasm, the sperm has got hardly any cytoplasm at all. Yeah. So in the sperm, there are no mitochondria. If there are mitochondria, they're so few that they hardly contribute to the mitochondria that are present in the zygote, and therefore from the zygote all the cells in our body are formed from the division of that first cell which has been fertilized, which we call the zygote, and therefore all the mitochondrial genes are got from our mothers. And the mitochondria, there are many mitochondrial genes that control how the brain functions. In fact, if you have, there are some genetic abnormalities in which you have mental retardation, etc., and it isn't in your nuclear genome. It is in the mitochondrial genome where these abnormalities are present, and these children are not very savvy because they are mentally challenged. So when the candidate said brain, sir, she was actually right, because it is the female that really has most of the bits of intelligence that we require for our everyday existence. Do you know also that females are more resilient than males? Do you know that females live longer? Perinatal mortality is very high in male neonates. Women live longer. And I don't know if you knew this, but once upon a time, the Y chromosome was equivalent in size to the X chromosome. And now it is, how much of the size of an X chromosome is the Y chromosome? Very small in comparison to the X chromosome. Everybody knows that, no? There's the X, which is a long, big chromosome, and the Y chromosome is a very small chromosome. So it is true that the Y chromosome has been slowly disintegrating. And if any of you is interested in embryology or knowing something about evolution, then you should read this book. It's called Adam's Curse. And this book tells you that men are becoming less and less relevant to human evolution. Now, of course, as a woman, I always knew that, but it's high time that men also realize that this is actually true. Okay, good. So now that we have established that it was not Adam that came first, it was Eve that came first. Eve will remain first and Eve will last forever. We can now go to our slide seminar. Okay, now you know how the slide seminar is going to function, right? Now I can't see everybody. I think Shabri has come, and I think Kayum has not got a very good internet connection. So let's go to the first slide. And these are the common gynecological specimens that you encounter. Now we'll just quickly go through it. Cervical biopsy is perhaps the most common, but some people might find that endometrial sampling, whether through curettage or anything else, may be almost as common as a cervical biopsy. Then, of course, you have a hysterectomy, you have all these other different things as we go down and also trophoblastic disease. In other words, that sometimes pregnancy goes wrong, or there is some reason to curette out a pregnancy that is wrong, and you get products of conception, and we need to know how to approach those products of conception. All right, now I can see three of you over here, and the person that is nearest to me in those little thumbnails is Aman, right, Aman?
Yes, ma'am.
Right, so now I think you can take case 1A and 1B.
Sure, ma'am.
Chalo, yeah, come.
Case 1A,
Yes.
female 37 years, presented with post-coital bleeding, and biopsy from the cervix is done. No clinical description of the biopsy area is provided.
All right. 1B.
1B, female 34-year-old female, vaginal discharge for over 2 months, last cell born over 10 years ago, and biopsy of the cervix is taken in the OPD.
All right. Very good. So now, in both cases, a biopsy from the cervix has been done. Have any of you seen how a biopsy from the cervix is done in the OPD? You've all been through gynec your postings, right? Yes? Yeah, so Aman, can you tell me how do they take a biopsy from the cervix? You can hear me, Aman?
Yes, ma'am.
Yes. So have you seen how a biopsy from the cervix is taken, Aman?
They use a speculum. They use a speculum, and with the help of that, they reach the squamocolumnar junction, and at the squamocolumnar junction, from there, if the lesion is present,
I see. So they use a speculum. They get a good view of the cervix. Yes, they expose the cervix, and according to you, that a cervical biopsy is taken from the squamocolumnar junction. Okay, Monish, have you ever seen a cervical biopsy being taken? Do you agree in general to what Aman said? Yes. Yes, do you agree? Monish, you can hear me, right?
Yes, ma'am.
Yeah, so just say yes or no. No, it is a simple matter. You just say yes or no. Do you agree to what Aman said, or do you want to add anything or subtract anything? You're shaking your head, you agree. Acha, Aman is right. All right. So, Sabri?
Yes,
Oh,
ma'am.
sorry, you wanted to say something, Manish. Say.
Nothing. He's correct.
He's correct. Okay, so three of you are correct. I can't see Qayyum, but Qayyum, can you hear me? Qayyum, can you hear me?
Yeah, ma'am, I can hear you, but I missed the part.
So then, can you?
Yeah, ma'am, I can hear you.
Very good. I can't see you, so because of the connection, but you can hear me. So do you agree that what Aman said? I think Aman was the first. Yes, Qayyum? I think we've lost Qayyum, but anyway, all three of you agree that you put a speculum in there, and then you take a biopsy of the squamocolumnar junction. Now, do you think that makes sense, Aman, or any one of you? When you see the cervix, you see something there to biopsy, right? Now, you see these patients over here. One has got postcoital bleeding. Yes. So somebody is looking to see if they can actually visualize from where this postcoital bleeding is coming, right? Similarly, when you had in case 1B, there is a vaginal discharge that's been going on for 2 months, and somebody is now trying to look for a possible lesion from where this vaginal discharge is coming from. All right. So let's see now what we see in the actual. So come on now. I know that this case 1B is a bit looks very light and very faded, but I want you, Aman, now to describe what you're seeing. First, you describe case 1A on the left and case 1B and at this magnification on the right. Would you like to describe it?
Yes, ma'am.
Right. Were you there at the last, when I took my slide seminar?
Yes, ma'am.
Yes. Do you think this is a high power or a low power?
It's the low power, ma'am.
Very good. So do you want to go by a particular system, or you just want to take a chance and do any kind of description that you want? It doesn't matter to me. It's your choice.
Shall I go with a description, ma'am?
Yeah, whatever you want. Yes.
Thank you. In case 1A, the photomicrograph reveals tissue which is partly lined by stratified squamous epithelium, and we can also see that there are multiple papillary fronts are coming out from the epithelium on the other side, and the stroma shows a few glands which are of a variable shape and size. In
Okay.
case of 1A.
Mm-hmm.
Whereas in case of 1B, in this magnification, there are multiple bits of tissue, and 2 of the bits are lined by stratified squamous epithelium.
Excellent.
And the larger bit reveals stroma, which comprises of variable sized and shape of glands.
You want to describe those glands a little bit? Maybe we'll see them at a little higher power. Anybody who's there, Munish or Qayyum or Shabri, do you agree with what he's saying? Is there anything else you would like to add at this power, or you're happy with what he has said? Yeah, anybody?
Almost agree.
Oh, all right. Okay, so you think that that's fine. Excellent. All right, next.
Shall I continue, ma'am?
Yes, of course. Please continue.
In the second slide of case 1A,
Yes.
you can see multiple papillary fronts, which are multiple papillary fronts are seen, and stroma comprises of glands of variable shape and size, and one of the gland is appears to be dilated, and it contains eosinophilic secretion, and papillary front is papillary projection of the lining epithelium is coming into the lumen.
All right. You. I think. Would you like to show what you mean over there? You can. I've turned the whiteboard on. Come on. Well, you can mark it so that everybody knows what you're talking about.
Ma'am, I'm talking about this.
Yeah, you've got a little pen, right? Use any color, it doesn't matter, because
Are you able to see this, ma'am? The color?
the color, no, I can't see it, but have you marked it? Has everybody been able to see it?
I have
No.
marked it with a blue color.
Yeah. Okay, does everybody see it? I don't think the blue color has come up. All right, but I think this thing that looks like an eye, no? That's what you are trying to mark?
Yes, ma'am.
Yes? It looks like an eye with a pupil at one end of the thing. All right, that's fine, doesn't matter. All right, now, would you like to say what you see in 1B?
Yes, ma'am.
Yeah, please.
In 1B, there is a tissue which is lined by stratified squamous epithelium. The stroma is fibrotic and comprises of glands of variable size and shape, and some of these glands are dilated, and while some have irregular outposts, and these glands are tall columnar epithelium with apical mucin, and occasional papillary fronts are also.
Yeah, you can't see the columnar epithelium very well here, right?
Yes, ma'am.
Okay, now you can see it better over here, although it's a bit pale. I apologize for that. And you see 1A on this side, yes?
Yes, ma'am.
Good. So anything more you want to add to what you want to see at high power over here?
In case of 1A,
Yes.
yes, ma'am. In case of 1A, these papillae are lined by tall columnar epithelium with apical mucin,
Okay.
and yes, ma'am. And the stroma within these contains inflammatory cells.
Okay.
I cannot appreciate which inflammatory cells.
All right. Excellent. Okay. Good. And this just shows you a higher power, which is the same thing. Okay.
Yes, ma'am.
Right. So, you have any thoughts on this?
Yes, ma'am. I think with the above history provided, in case of 1A, with the above history provided and the stomophysical findings, I have made a diagnosis of papillary endocervical reparative change without atypia.
Okay. Papillary reparative change without atypia. Okay. And in 1A and in 1B?
1B, it is with the above history provided, and since since the finding shows that the endocervical glands, the overlying epithelium is the stratified squamous epithelium.
Yes.
And because of that, I found that I think it is a mature squamous metaplasia.
Natural squamous metaplasia.
Mature
Mature squamous metaplasia. All right.
metaplasia.
Good. You want to? Can I ask the other two? Do you agree with what he has to say?
Yes, ma'am.
Do you agree? So you
Yes.
would have called it natural squamous metaplasia, and this one you would call what, Manish?
Yes, ma'am.
What would you call it?
Yes.
What is 1A?
One is, ma'am, endopapillary cervicitis.
Endopapillary cervicitis. Yes. What about Shabri?
Madam, I would consider endopapillary cervicitis.
And 1A and 1B?
1B, endocervical polyp.
Endocervical polyp. Okay, good. What about you, Kayum? Now I can see you. What did you think about 1A? Kayum, can you hear me? Can you hear me, Kayum?
And
Okay.
Unmute
yourself, yeah.
Yeah, ma'am.
Okay, 1A is what?
1B, we can see 1A is, ma'am, papillary
Papillary endocervicitis. Yes? Kayum, I've lost you in between. Anyway, let's just put down what we have seen, okay? Case 1A, you were absolutely right, Aman. You said there was essentially unremarkable squamous epithelium in 1A as well as in 1B. Wherever this squamous epithelium was seen, it was essentially unremarkable. Then you had areas where the glandular epithelium, in 1A was papillary and congested. Yes or no? There was lots of blood vessels there.
Yes,
And in 1B, you have unremarkable endocervical glands. Okay? And here you had some mild inflammatory infiltrate, which you, you described that very well. And there was no inflammatory infiltrate in 1B. So now, maybe I can ask, what are the possibilities? Okay, now you guys, you'll have to take your pick. Okay, case 1A, there was inflammation, there were some papillary-like projections, and so you have this the choice. Okay, there should be a D over here as well in this, but it's not come up over here. But
Ma'am, it is there in the next slide, ma'am.
is there in the next slide? Okay, very good. Sorry. Now tell me. What will you pick? Come on quickly, while they are, Aman, you tell me, which one will you pick?
I'll pick my papillary endocervicitis.
So you take C. What about you, Manish?
Ma'am, C.
C.
Chronic
Correct.
papillary endocervicitis.
Papillary endocervicitis. Yes. What about you, Shabri?
Third one, C.
Third one. Very good. C. And Kayum?
Ma'am, C, chronic papillary
Papillary
endocervicitis.
endocervicitis. Okay. What have the others said, Cheta?
Yes, ma'am. So for 1A, the possibility, 51% people have answered for papillary endocervicitis
Okay.
and 49% for chronic papillary endocervicitis.
Yeah. So that means almost everybody has. Yeah. And then what's the rest?
It's
Chronic cervicitis, I suppose.
yes.
Yes? All right. You know what the answer is? It's D. It's none of the above. It's not chronic papillary endocervicitis. It's not papillary endocervicitis. It is not chronic cervicitis. It is none of the above. And we will discuss why it is none of the above. Now, let's go to case 1B. We have 4 choices over here. Unremarkable cervix, and that I think is somewhat what Aman said. Chronic cervicitis, chronic endocervicitis, and none of the above. Now come on, what will you guys choose? Aman?
Unremarkable cervix.
Unremarkable cervix, okay. What about you, Manish?
Ma'am, chronic cervicitis.
Chronic cervicitis, very good. What about you, Shabri?
Third one.
Chronic endocervicitis, all right. And Kayum?
Ma'am, it's unremarkable cervix.
Okay, all right. So what are our
Ma'am, the audience, 43% have chosen unremarkable cervix,
okay,
29% chronic cervicitis.
okay. Did anybody choose none of the above?
And let's check now.
It is none of the above. Okay. And I asked right in the beginning, have you ever seen a cervical biopsy being taken? Okay. And if you have seen a cervical biopsy being taken, then you would know that when you see the cervix, you are not seeing the endocervix. Are you seeing an endocervix? What are you seeing? When they put the speculum in, what is that part of the cervix that is being seen? What is it?
Exocervix.
Ectocervix.
Exocervix. Very good. Now, what should the exocervix be lined by?
Stratified
Stratified
Stratified squamous epithelium. Everybody agrees, right? So now from where have the endocervical glands and the endocervical epithelium come from? Do you think somebody went and shoved that lesion through the external os into the endocervix? Is it possible?
No.
Without dilating the endocervix, can you actually put and you are taking a punch biopsy. You know what is a punch biopsy? It's got a little opening at, where you have a hinged bit which you can open by pressing on the holder, and you'll see that you can then take a little bit. So the real question that you had to ask yourself is, where did the endocervical tissue come from? So now please answer that question. Where did the endocervical tissue come from?
From the transformation zone.
Transformation zone. So what is this transformation zone, Aman?
Normally, what happens is that there is a exocervix in the outward, and the endocervix is present in the inner aspect.
Yes.
At puberty, this endocervix comes outward due to the hormonal effect, and this endocervix is then ultimately because of the change in pH or other infection or chronic irritation, this pulmonary epithelium is replaced by the stratified squamous epithelium, and that zone, and that is the newly formed zone, and that zone, and from the originally formed transformation zone, that space originally formed squamous conjunction, that space is known as transformation zone.
Yes. So what is below the squamous epithelium in the transformation zone? What should you find? Should you find anything? Should you find glands still remaining over there, or not?
Yes,
Because we just said, no, that the ectocervix should have squamous epithelium.
Yes, ma'am.
Yes?
Yes, ma'am.
Yes.
So what is the diagnosis? Have you ever heard, has any one of you, you're all up your third year now, right? Have you ever made a diagnosis of cervical ectropion? Any one of you has made a diagnosis of a cervical ectropion? And the answer is no, right? Have you ever made a diagnosis of squamous metaplasia occurring in an ectropion? No. Now, have you heard the term at all, ectropion? You have, right? In gynecology, they talk about ectropion all the time. So what is this ectropion? It's exactly what Manish, who was describing it? Aman was describing now. All right, under physiological conditions, often during pregnancy, at puberty, sometimes even nearing menopause, you get columnar epithelium that comes onto the ectocervix. Yes, and that looks red. It looks red, and that's why the gynecologists often call it a cervical erosion. But it is not an erosion. It just looks red. Why does it look red? Any idea? Why does it look red? What does the normal cervix look like? It's pinkish white, right? So when you see this, it looks red. Why does it look red? Because columnar mucosa
Con-
allows, and you saw,
congestion.
there was vascular congestion. Whether there is vascular
Congestion.
congestion or no, it is vascularized, and you do not have the layers, the number of layers of the squamous epithelium to prevent, like we discussed in leukoplakia. Do you remember that the epithelium looks white when you have a certain thickness through which the light has to penetrate? So it looks red, and the gynecologists often use this term erosion, and they call it a cervical erosion, but truly it is an ectropion. That means you get columnar epithelium that is now present on the surface of the ectocervix. Right, and what Aman was describing is when that squamous metaplasia occurs, meaning it was now glandular and it has to go back to being squamous, that is a metaplasia, no? What is metaplasia? How do you define metaplasia? How do you define metaplasia?
Replacement.
Metaplasia when one well-differentiated lining epithelium is replaced by another differentiated one.
That's right, Aman. So first you had a glandular metaplasia, which we call an ectropion, and then you have a squamous metaplasia, which over that glandular metaplasia, and that is what we often call a healing cervical erosion. Okay, there is no erosion, there is no question of healing, it is merely metaplasia. And you can see this, Now I just ask you, if you have this algorithm, where would you put this particular thing? The first question you ask yourself, is it congenital or acquired? What would you say this is? Congenital or acquired? Acquired. Very good. Is it physiological or pathological?
It's physical.
Yeah, it's physiological. There's
Physiological.
nothing pathological about it. And you know why that woman was having vaginal discharge? Tell me why she was having vaginal discharge. Huh? Because the glandular epithelium is secreting mucus. Okay, so now you understand exactly what is happening. So there is no such thing as chronic cervicitis. There is no such thing as papillary endocervicitis. There is no such thing as just chronic papillary endocervicitis. Please, there is such a thing as cervicitis, but that is the rare, not the rare, but you do get candida, you get Listeria monocytogenes, you get some, trachomatis, you get chlamydia, but that's not what this is. And the way that you should have thought about it is, a biopsy is being taken from the ectocervix. So where has the endocervical epithelium come from? Do you get me? Yes. So in a cervical biopsy, if you ever see endocervical epithelium, how do you account for that? Come on, Qayyum, if you ever see in a cervical biopsy, punch biopsy from the cervix, glandular endocervical epithelium, how do you account for that?
Physiological.
Physiological what? Physiological what? What is that condition? It's right there on the screen in front of you. What is it called?
Ectropion.
It's called an ectropion.
Physiological ectropion.
Yes, it is an ectropion. You don't have to call it physiological ectropion. You just have to call it an ectropion. All right? So, whenever you see glandular epithelium in a punch biopsy of the cervix, there is an ectropion. And that ectropion is either entirely columnar or it is undergoing squamous metaplasia. Have you understood that? Absolutely, yes. So this is all about this transformation zone and the squamocolumnar junction. This is how a cervical ectropion looks like in the reproductive age group. Okay, you see normal ectocervical epithelium here, which looks white. Then you see this cervical os there. Can you see it right in the middle? And you can see something that looks very red and agree that is the ectropion. If you biopsy that, what will you see? Come on, what will you see when you biopsy that?
We'll get both the.
Qayyum, I want Qayyum to answer. What will you see when you biopsy this red area on the right? What will come in your biopsy, Qayyum?
We will see the epithelium.
What epithelium?
We will see the epithelium. We will.
What
squamous epithelium.
What type of epithelium, Qayyum?
Squamous epithelium underlying columnar cells.
So you think this red part that you are seeing over there? 1 second. I think Shweta, can you move them down to the bottom, because I can't do it from here.
Yes, ma'am. I'll do that.
Just move them, because then I can. If you can just move.
Is that all right, ma'am?
Yeah, absolutely. All right, so I can make this transparent. You know, that thing hides the. All right. So now you can see. You can see this red part.
Yes, ma'am.
Yes. So if this red part, you take a biopsy of this red part, Qayyum, what will you see in your biopsy? What will you see under the microscope?
There will be.
What will you see?
There will be. There will come the epithelium plus stromal tissue, elastic tissue, fibroelastic tissue.
Qayyum, can you hear me?
Ma'am, now it will come.
What do you mean?
It will come as endocervical epithelium.
Absolutely. So you will
endocervical epithelium, that's columnar epithelium.
Yes, you will see glandular epithelium. You will not see squamous epithelium. All right, very good. Now, if I took a bit of tissue from here, can you see this white thing, Qayyum? This white part? Can you see the white part? Yes.
Yes, ma'am.
So what kind of...
yes, ma'am.
What will you see under the microscope?
And here we will see the squamous part.
Yes, so you will see squamous epithelium, right? And that is what the normal cervical epithelium should look, ectocervical epithelium should look like. But when you see this reddish thing over here, which you saw, yes, you see this reddish part, it looks as if there is an ulcer, as if there is an erosion, but it is not. It is columnar epithelium, and this is what we saw in case 1A. Now, when this columnar epithelium is overrun by the squamous epithelium by metaplasia, that's what we saw in case 1B. All right? 1B. Yes, absolutely. So are all four of you now convinced?
Yes.
Yes, very good. So now there is a new term that you have to learn, has to come into your diagnostic armamentarium, and that is cervical ectropion. And the more you look for it, the more that you will find it. So if you look, this is a section from a normal cervix of a 40-year-old female. This is just a normal cervix. There's nothing wrong with the cervix. And what do you see? You see the squamous epithelium. There's a bit that has fallen off over here. And then you see the, the endocervix. Now this endocervix, how does it look? Any one of you? You've been describing papillary. Doesn't it look papillary?
Yes, ma'am.
Yeah, but this is normal. So it is, this appearance of the endocervix is absolutely normal. Normal endocervix does not have those beautiful glands that you imagine. Go and look at normal endocervix and you'll be surprised at how papillary it looks. It is not actually papillary. It is actually racemose. You know, it is like the glands or have got little outpouchings to the glands. That is the meaning of race moles. And when it is cut tangentially, you see this kind of papillary appearance. So what you saw in case 1A is nothing but the normal appearance of what? Of what? Endocervix. Okay? So there's nothing wrong about it. It was just an ectropion which was showing you the normal appearance of the endocervix. And what Aman was telling you is exactly this. Okay? This, we start off all cervices start off before menarche as a small little os, and there is a small little area which we call the transformation zone around it. After puberty, you see the os and you see a large area which I just use this whiteboard to show you. I think I need to make this go there. Yes, you can see now. Do you see this? This is the. You see this black line over here? This black line is showing you where after puberty you get an ectropion. You really do. But nobody goes in there. Nobody has any business looking into the cervix of a pubertal girl because she has not really had sexual intercourse. But if you did look at it, that's what it would look like. It would look reddish. Then after puberty, between the ages of 30 and 40, once again you get this white part is the endocervix, the exocervix, and you do see sometimes these physiological areas where you do get what we are calling an ectropion, all right? And this, when the squamous metaplasia occurs, you still see some glands that are present at the periphery. Do you see these little dots that are there? I will show you where the dots are. And that is the original squamo-columnar junction. You see these dots over here now? These little dots, that's where the original endocervical tissue was at the time of puberty, but by the time you become, the cervix is reproductive, it is all covered by squamous metaplasia. And you see this squamous metaplasia in the next slide. See this. This is the normal endocervix. Sorry, I'll just take that off. I can't clear it, Shweta, because I think you put them up on the. All right, I'll remove the whiteboard.
I'll just change, ma'am.
Oh, that's okay. If you can move them to the other side. Okay. You see this? This is the normal squamo-columnar junction, which you see in all normal cervices. This is absolutely normal. This is just a section of the cervix, and you don't see this papillary structure is normal. Now, see what happens when you get metaplasia. What kind of epithelium is this? Squamous, right? But does it look like this squamous epithelium that you're seeing on the left-hand side of the screen? Does it look like that?
No.
No. Why?
No.
Why? Because this is what we call immature squamous metaplasia. You see, it is bluish.
Yes.
So this is immature squamous metaplasia, and that is what happens at the transformation zone. You get this immature squamous metaplasia that is going from mature squamous epithelium over this endocervical epithelium which had crept out onto the exocervix. Okay? Any questions on this particular thing? This is you're not the only people who have this problem, huh? You just see this. The International Agency on Research on Cancer has shown that many people have problems with this kind of epithelium, and it's very important for you guys to realize that the transformation zone or an ectropion is exactly what we are seeing. People even call these things carcinomas and so on, so you have to be very careful. Are there any questions on the...
Yes, ma'am.
Yes.
So there is a question saying, is the term papillary endocervicitis wrong?
I think it's wrong, because it is just normal endocervix that is out onto the, which has is part of the ectropion, which has come out onto the cervical, ectocervical mucosa. It has replaced the ectocervical mucosa. So there is no such thing as papillary endocervicitis, or for that matter, chronic papillary endocervicitis. Any other questions?
No, ma'am.
Yeah, so if anybody is using that terminology, just review that terminology and see whether you want to continue using it. Okay, I don't use it. Those whom I have sort of taught seem to be convinced that there is no such thing as papillary endocervicitis. Okay, good. So can we go to the next thing now? All right, so let's come to the next case. And we have case 2A, and who wants to take 2A, because somebody else can take 2B. We have 4 people over here. All right, now next to Aman was, come on, in my screen is Monish. Come on, Monish, read.
Case 2A is 29-year-old female, nodule in broad ligament, discovered at cesarean section for obstructed labor.
Excellent.
The cause of obstruction was a large uterine mass, possibly a fibroid.
All right.
The section shows lining of mesothelium, and below mesothelium a submesothelial tissue, or above this peritoneal fat.
Okay, very good. So you want to go to the next thing? Yes, come on.
In next section, it also shows mesothelial lining. Mesothelial lining, submesothelial tissue, and check. In next section, and some hemorrhage-like areas. And in next section, it is mesothelial lining showing under mesothelial lining, submesothelial tissue is showing decidualization.
Are you interpreting, or are you actually describing?
Sorry, describing.
You're describing. So please describe then. What are you seeing?
Cells in this section, cells are these are pleomorphic cells showing abundant amphiphilic cytoplasm. Amphiphilic cytoplasm with pleomorphic nuclei and sprinkling of lymphocytes.
Okay. Shweta, I don't have the button to do next.
Okay, ma'am. I'll just, this ends here. I will just put on the next slide.
Yes. Yeah, good.
And this is the hypoverview showing decidual change.
Are you describing or are you interpreting?
Showing large pleomorphic cells with abundant amphiphilic cytoplasm with eccentrically placed nucleus and sprinkling lymphocytes.
A sprinkling of lymphocytes. Are you sure that those are lymphocytes? Are they lymphocytes? And where are those so-called lymphocytes? In the tissue, or in where? In the stroma, or where?
In the stroma.
In the stroma. Anybody else wants to say anything else? Add, subtract from what Monish has said? Shabri? You agree? Shabri, can you hear me?
Yes.
Is it yes or no?
Yes.
Yes. Kayum, you agree with what
Ma'am.
said? Okay, so you agree. What about you, Aman?
Yes, ma'am, I agree with him.
Okay, what can you see stroma here at all? Do you see stroma? No, you don't. So then where
No.
are all these so-called lymphocytes seen? Huh? Where are they? What do you see as the only or the majority stroma over here? I mean, there may be a little stroma here and there, but majority, what do you see? You see blood vessels, no? So there are thin-walled blood vessels that are present in this stroma. And when you look carefully, you see these, what you are calling lymphocytes, but many of them are polymorphonucleoleucocytes. And yes, there are lymphocytes that are actually stuffed in the blood vessels that are seen in this within this stroma. Okay, can you see the dilated blood vessels? Or you can't see them? You can?
Yes,
Yeah,
ma'am.
yeah, they are. There they are. You can see them. And all these things are stuffed within the blood vessels, which are the only kind of stroma that you see. Okay. So what was your diagnosis? Yes, Manish? Manish, what was your diagnosis?
Peritoneal decidual reaction.
Right. Yeah. Did you attend the, the meeting that was held in Karnataka, Belgaum conference? Were you there? Yes,
No,
Manish? No, ma'am. Okay, very good. Because I think if you weren't there and you reached this this diagnosis, it's very good. So let us start with what we would like to do. Okay, and that is, let's answer this question. Is there any normal tissue or structure present?
Yes.
Shabri? Yes or
Yes.
no?
Yeah,
There is. What is the normal structure?
it's the peritoneal mesothelial lining.
It's the mesothelial lining. Okay. Is there a difference between peritoneum and mesothelium? Is there? Is there a difference between peritoneum and mesothelium? Answer is? Yes, come on, Kayum. Oh, yes, yes. What is the difference?
The peritoneal cavity is lined by mesothelial cells.
Very good. But what is the peritoneum? You know, when a surgeon incises the abdominal wall, yes, what does he incise? What is the first layer he incises? When a surgeon puts an incision in the abdominal wall, what does he incise?
Incises the parietal peritoneum.
Correct. First layer, the outermost layer is parietal peritoneum.
The outermost.
What is the outermost layer? You don't think he's incising the skin?
Yes, he's incising.
Yes. Okay, so he's incising skin. Very good. What's the next layer under the skin?
Subcutaneous.
Subcutaneous tissue. Excellent. What is the next layer under the subcutaneous tissue?
Fascia.
Fascia. Excellent. Then what's underneath the fascia? Yes. So there is the external oblique or the internal oblique, or if it's a midline thing, then of course you have the rectus, the fascia that connects the two parts of the rectus abdominis. And then what is the last layer that he incises?
Peritoneum.
Peritoneum. Very good. So now Shabri, he incises the peritoneum. So what is he incising? This thin mesothelial layer. Do you think he's doing that? He can see the thin mesothelial layer to incise it. What do you think? No. So what is the peritoneum? Yes, Kayum, what is the peritoneum? It can't be just mesothelium, right? So what is it? Aman, what is it? It has to be what? It has to be. It has to be the mesothelium supported by connective tissue and fat. That is what is the parietal peritoneum. Okay, so you can't tell me that peritoneum is just mesothelium. It's the same way that skin is not epidermis. What is skin? Skin is epidermis and
dermis.
Dermis. So when somebody is incising the skin, they're incising the epidermis and the dermis. So please, there is a mesothelium on the outside, and then there is this connective tissue which supports that mesothelium. There is also a bit of fat. All together, this forms the parietal peritoneum. Okay, you understood this now? Very good. All right. So is there any normal structure present? Yes. It is this mesothelium, and there is the submesothelial adipose tissue. So is there any abnormality present? What's the answer?
Yes, ma'am. The pale-looking area.
Yes, there is. Very good. What is the relationship of the normal to the abnormal?
No relation.
No relationship. Shabri, there is no relationship. Do you understand what is the meaning of relationship, Shabri? What? What? What is the meaning of relationship? Will anyone, one of you want to tell him?
Madam, the decidual cells are separate from the normal structure.
I see. So the decidua came from the uterus and implanted itself over there. Is that it, Shabri? Monish, you made this diagnosis, no?
Yes, ma'am.
What's your diagnosis? Sorry. What is your diagnosis?
There may be a relation because mesothelial cells can, under the influence of hormone or any pregnancy, can convert.
I see. So according to Monish, mesothelial cells under the influence of hormones get converted into decidual cells. Do you think that's right, Aman? What Monish is saying?
Yes, ma'am. The subcoelomic mesothelial cells under the effect of progesterone can show some metaplastic change and
to decidual cells. That's what you believe. Okay. So according to the three of you, and I can't see Kayum, from here, let me just put that whiteboard on and take that from here to here. These are all mesothelial cells, and they are metaplastic, and they become metaplastic, and they are decidua. Is that what you're saying? Is that what I understand you're saying? Say yes or no. Yeah? I thought that the mesothelium is a thin layer that is on the surface, right? Now what you're telling me is that all of these from here to here, everything from here to there is all mesothelial cells. Kayum, do you agree? You saw what was there, right? From here to here, according to, your three companions, everything from here to, I don't know why it's not marking, but maybe it's my, everything from here to here, it's not marking for some reason. All right.
Only the stromal cells, ma'am.
Huh?
Only the stromal cells will show this metaplastic change. But not the lining epithelium.
I think there is, that's okay. Now I cannot make this, I seem to have a problem. I can't move that one to make it transparent.
Okay, ma'am. It's not coming left side, ma'am. We can try it again, ma'am.
Okay, I'll try it again. Okay, I'll turn this on. I want to make now it has become transparent. Oh, there was a bit of an issue. Okay. So you're telling me, who said that? What did Qayyum say? Qayyum said something. No, it went. Let's go previous. I need to go previous to this also. All right, never mind. So I think it is. Do you know what becomes decidua in the endometrium? What becomes decidua in the endometrium? Decidua occurs in the endometrium, right? Yes or no?
Yes, ma'am.
Yes, ma'am.
So Manish, tell me, what part of the endometrium becomes decidua?
And stromal cells of endometrium becomes decidua.
Decidua. The glands don't become, right? So why do you feel that the mesothelium should become decidua? What should become decidua?
The stromal cells.
Yes. So it isn't the lining epithelium that becomes decidua. It is the stromal cells. And where are those stromal cells? In the peritoneum, right? So the peritoneum is mesothelium, underlying stroma, which is supporting that mesothelium, and plus minus the fat that is below that. That is what is parietal peritoneum. So it's the mesothelium doesn't get converted into decidua. What gets converted into decidua?
Stromal cells.
The stromal. The
Peritoneum.
stromal cells means what? The stroma that is supporting the mesothelium. The stroma of the peritoneum. That is what is there. So what is the relationship of the normal? That's the mesothelium and the fat. There is a sharply demarcated nodule in between the mesothelium and the adipose tissue, which is where the peritoneal stroma is. Okay, and that is what is showing you this abnormality. Is there a pattern to this abnormality? And the answer is yes. It is diffuse and sheet-like. And then where you want to direct your high power, you can direct it anywhere in that nodule, and you see the high power over here. So then what is the way that we do this? Is this congenital or acquired?
Acquired.
It's acquired. Okay, very good. Is it physiological or pathological?
It's physiological, ma'am.
Yes, it is physiological. And so what's the diagnosis then?
Peritoneal testicular reaction.
Yes?
Peritoneal.
Peritoneal testicular reaction.
Physiological, and it is physiologically decidualized peritoneum. It is not physiologically decidualized mesothelium. Have you got you've got it right now or not?
Yes, ma'am.
Okay, very good. So that's very good, Monish. Let's go to the. I just want to show you this. This is we don't need this histochemistry for diagnosis, but you can see the mesothelium. The mesothelium expresses cytokeratin, right? Yes or no? Yeah, very good. What does decidua actually express? Should it express cytokeratin?
No, ma'am.
No. So you see the decidua expressing vimentin. You can see it over here, whereas it has not expressed cytokeratin. But you see something else that is interesting. And what do you see? You see over here the lining epithelium, which are not the lining epithelium, the mesothelium. What is it? Has it expressed vimentin or not? And the answer is yes. It has expressed vimentin. So mesothelium is a modified mesodermal structure. So it will express cytokeratin, but it will also express vimentin. Do you know any other structure in the genital tract of females that will express cytokeratin and also express vimentin? Do you know any other structure? It is the endometrium. The endometrium is a epithelium. It's a modified epithelium because basically what was it? The Mullerian system comes from where? From the mesoderm, right? Yes, so the Mullerian system comes from the mesoderm, and that's why it is important that you understand your embryology. It comes from the mesoderm, and that epithelium, which is the endometrium, also expresses vimentin. And if we want to make the distinction between an endocervical carcinoma and an endometrial carcinoma, we often use two different immunohistochemistry markers, CA and vimentin. Vimentin is expressed in endometrial, normal endometrium, as well as in endometrial carcinomas, whereas CA is expressed in cervical carcinomas. It's not expressed in normal cervical epithelium, but it is expressed in endocervical carcinomas, and it is not usually expressed in endometrial carcinomas. All right, so now you learned something about that. We'll go to this next case, and who's going to do that? Qayyum, you want to do it?
Yeah, ma'am.
Yes? Very good. So let's go to the next case now, which is 2B.
Ma'am, it's a perimenopausal woman experiencing heavy, prolonged menstrual bleeding for the first time.
All right, come on now. Now describe.
We have been given the We have been given the H&E stent sections from the endometrial biopsy, which shows the glands which are cystically dilated. Some are smaller and some are larger glands, which are I can see are lined by the low columnar cells.
Okay.
And the gland inside the glandular lumen, there's secretions accumulated.
Okay.
Ma'am,
Yes. Qayyum, when
Yeah,
you
ma'am.
is there anything else you'd like to say?
Ma'am, in this slide, there is the gland. Glands are like a saw pattern.
Like a sawtooth? What did you say?
Sawtooth pattern. Yeah, ma'am.
All right. Do you see anything else besides glands?
Ma'am, then there's a stroma.
Ah, there is a stroma. Very good.
Stromal. I can see stromal reaction actually.
Stromal
With
reaction. Acha. What do you mean by
with,
stromal reaction, Qayyum?
yeah, ma'am.
What is the meaning of stromal reaction?
Ma'am, it is the reaction of the stromal in which the extracellular matrix and other inflammatory mediators or inflammatory cells gets accumulated.
Qayyum, at this far, you are being able to see inflammatory cells and so forth. Huh?
Here I can see the inflammatory cells. Firstly,
you can see in inflammatory cells, Qayyum. Anybody else can see inflammatory cells? Yeah? Anybody else can see inflammatory cells? Say yes or no.
No.
Somebody, can you see? No, so they can't see it. Now, what do you see here? Now, here is your stroma.
Ma'am, there is the in the lower part of the right side slide, there is the distalization of the stroma, and we can see the capillaries, arborizing capillary network.
Very good.
And ma'am, then we can see the cells which have bubbly like cytoplasm.
You can see cells with bubbly cytoplasm. Acha. I can't see them, but maybe somebody else can. Okay. So, what is your diagnosis, Qayyum?
Ma'am, it can be the histomorphological features are consistent with the secretory phase. It's actually secretory phase, late secretory phase of menstrual cycle, or it's a late secretory phase due to the destabilization due to the exogenous hormonal therapy.
Okay.
Maybe progesterone.
Very good. Okay. So you think it's a late secretory phase. All right. Very good. Shabri, what do you think? Shabri, can you hear me? No, he can't hear me. All right, Monish, can you hear me?
Yes, sir.
Yes. So, what do you think?
Secretory phase.
Secretory phase endometrium. All right. Tell me, what about you, Aman?
Yes, ma'am. It's can be a late secretory phase.
Late secretory phase endometrium. All right. So let us start now. Is there any normal tissue over or structure over here?
Yes, sir.
Yes, ma'am.
There is. Which
Yes,
is
ma'am.
the normal
Yes, ma'am.
structure? Which do you think is the normal structure? Who said yes? Monish, you said yes, or Kayum
Yes,
said
ma'am.
yes? Kayum is answering. So do you think there is? The answer
Yes,
is no. There is no normal structure. Why? Is this endometrium? This obviously is a curettage, right? There are multiple fragments here, so it's a curettage, right? Good. So now tell me, what is normal in this?
And according to secretory phase, they are tortuous glands.
According to this, so these glands, are they tortuous? Do you know what is the meaning of tortuous? Tortuous means, what kind of mental picture do you get for tortuous means? Do you get a picture of branching, or do you get a picture like a corkscrew? What is the picture that you get in your mind? Kayu, do you think that these glands are tortuous?
These are tortuous actually.
You think that
Irregularity in glands is seen.
irregularity is not the same thing as tortuosity. Irregular does not mean tortuous. What is tortuous?
Some glands show tortuous.
No,
And,
what is tortuosity, Kayum? Do you understand?
there is one more thing, ma'am. There's a gland inside the gland.
Gland inside a gland. Okay. What is the meaning of gland inside a gland? You know why that gland inside a gland occurs?
It is a telescopy, ma'am.
Telescopy. Yes. So for something to telescope, how should it be?
Ma'am, in case of telescopy, what happens is that
Gland inside the gland.
the gland comes within the lumen of the another gland, and it occurs mainly due to the mechanical disruption. And there is
Doesn't
some
happen
snap.
because of mechanical disruption. Do you
Can
know
occur
what a
as the
corkscrew is? Do you know what
artifact.
is a corkscrew? What is a
Can
corkscrew?
be artifact telescoping.
Huh? Sorry? What is a corkscrew? Have you seen something that's a spiral?
The spiral.
Ah,
The spiral
now,
screw.
yeah,
Cuts-
that is what is a that is tortuosity. Okay, it is like a spiral. Now imagine when you are cutting that gland, yeah, what will happen, because there are two lumina that are close to one another and you cut it tangentially, you'll see one lumen inside the other. Mentally try to cut a spiral and you'll see that it's one gland inside the other. Yes, there is a telescoping, but that is not true. That really doesn't telescope. It is not something like what you get in an interception. An interception is a real telescoping. You know what is an interception? That occurs in the small intestine. Yeah, when one part of the intestine is pushed into another part of the intestine. That is telescoping. This is tortuosity, which is like a spiral. Okay, so that's not what you are seeing over here. What are you seeing here? The glands are not tortuous; they are branching. Can you see that?
Yes, ma'am.
Yes.
These glands are They are
ma'am.
branched. This is not the kind of gland that should come along with, which is something that is obviously decidualized. If you have a decidualized endometrium, you should have corkscrew or spiral type glands, and you don't have spiral type glands over here. You are getting branched type glands. Some of them are very dilated, and some of them are very small. This is a very odd type of gland to get with a decidualized stroma. So those people who said that this is a secretory phase endometrium, it is not a secretory phase endometrium. Okay, there is nothing that is normal. There is an abnormality over here, and this abnormality, abnormal glandular outlines and lumina, you can see them. They're irregular lumina with branching. So is there a pattern to this abnormality? And the answer is yes, there's a prominence of the stroma which is pink and abundant in many areas, and you have rightly called this decidualized. So now where do you direct your high power? You can direct it anywhere, but you have to look at the glands and you have to look at the stroma. Now you tell me, is this congenital or acquired?
It's acquired.
It is acquired. Okay, why do you
Acquired.
think it's acquired? Monish, I'm asking you, why do you think it is acquired?
And because in question there is no history, family history.
Because there's no family.
It's first.
That's why. It is acquired.
It's not.
Bolo. Yes, Monish has his turn is fast. Now, Qayyum, why is it acquired? Why is this not congenital?
Not
Ma'am,
present for-
this female is experiencing first time the bleeding.
So
She has not experienced bleeding in the previous around 34 years.
she has not
33 years
experienced bleeding. She has experienced bleeding. What was
previously.
it? It is prolonged menstruation. Otherwise, she's been menstruating, Qayyum, except that this time it is prolonged menstruation. So you think that this may be congenital?
Prolonged, heavy bleeding.
No. Well, Shabri, what do you think? Why is this acquired?
No.
Shabri, can you hear me?
No normal structure seen.
That's why it is acquired. Yes. Aman, why is it acquired?
Ma'am, it is because it is occurring in the perimenopausal age group, and
Come on, this woman is 45 years old. No, she's been menstruating normally. The first time she's had this. How can something like this be congenital, for God's sake? This is a commonsensical question. And when a commonsensical question is asked, you have to have a commonsensical answer. It is acquired. Yeah, because this is in an adult female who has had no problem before. It's the first time that she has had prolonged menstruation. Nothing can be congenital and keep on like this for all these so many years. All right. Is this physiological or pathological?
ma'am, it is pathological.
It is pathological. All right. It's pathological. So what is this? Now, what is this?
Yes, ma'am. Since there is a discordance in the development
Glands.
of the glands and the stroma, the stroma appears to be decidualized, whereas the glands are shows the branching pattern, which is not seen in case of the late secretory phase. So we can say that there is some lag in the development of the glands and the stroma. So by this we can say that it can be because of the endogenous hormonal influence. There is abnormality in the normal cyclical changes. There is abnormality in that, and so it can be the dysfunctional uterine bleeding, probably because of the luteal phase defect.
Luteal phase defect. Now, he's come up with a very interesting thing. Luteal phase. So what is the defect in the luteal phase, please, Aman?
In case of in this luteal phase defect, it is said that the problem lies within the pituitary or the hypothalamic tissue, because of which the follicular stimulating hormone and luteinizing hormone are not secreted properly, because of which the progesterone level is not raised, not increased, which is needed for the secretory changes.
There is deficient progesterone, right?
Deficient progesterone.
Yes or no? Yes.
Yes,
So
ma'am.
the progesterone is deficient.
Yes.
Now, do you think the deficient progesterone will decidualize the stroma? Aman, decidualization of the stroma occurs as a result of what?
It's because of the progesterone.
Progesterone.
Yes, and now you're telling me that this is a luteal phase defect. So really, what is the problem over here? It cannot be. There is too much progesterone. No, the stroma has been decidualized, so it cannot be a deficiency of progesterone. So now, Qayyum, you started off very well. You told me that this was a secretory endometrium, yes, which was due either to what or what? Come on, what did you say? You gave me two possibilities in the beginning. So what are those two possibilities? What were the two possibilities?
That it's because of there is a decidualization. You can say pseudo decidualization
All right.
due to hormonal therapy.
Or hormonal therapy. You said that. So which hormonal therapy, and why is this hormonal therapy given?
She can be on oral contraceptive pills like progesterone.
Progesterone is not given as an oral contraceptive pill.
Levonorgestrel or combined
with estrogen.
Levonorgestrel.
I don't think that
Combined.
we are on the right track. All right. Now you know what the answer to that is. It's not neoplastic, obviously. This is an iatrogenically progestationalized endometrium. What does that mean? When do you give progesterone to a woman? And you know what her history was. What is her history? She's had a prolonged period. Yes? And now somebody has given her progesterone. Why? Why?
Maybe because of the bleeding to control the.
Yeah, so why was she bleeding? What was the cause of her prolonged period? And you saw it. You saw it in that endometrium.
Deficient.
That, huh? Why? Why do people have prolonged bleeding? Any idea? Because they are bleeding from an endometrium that has very little progesterone. Okay, it is an endometrium which has been estrogenized, but there has been no progesterone. So what is this endometrium which has been estrogenized and there is excessive estrogen, but there has been no progesterone? So what is that kind of endometrium called? No, you know it. What is it? No? You've not made this diagnosis ever in your life? That this is a hyperplastic endometrium which is showing disordered proliferation. Have you heard about disordered proliferation? Yes, you have. You have made that diagnosis previously in your life. Okay, so let us quickly now understand this endometrium. Okay, what is this thing that is happening in the endometrium which you guys don't seem to be able to fathom in terms of the action of estrogen, progesterone on this endometrium? All right, what do you think this particular picture shows over here? Can you see the picture? What is this? Can you see the picture? Yes. What does it represent? It's a section, right?
Yes, ma'am.
A section of what?
This is a section showing endometrium as well as myometrium.
It is a section of endometrium, very good, and a
Myometrium.
portion of myometrium. All right. So how do you think this particular section has been taken? Where does it come from?
Proliferative phase.
No, that's not what I want to know. Is it a hysterectomy or some other? Is this a hysterectomy?
Yes, ma'am.
Who votes for hysterectomy? Come on. Aman, do you think it's a hysterectomy? That this is a section from the endometrium from a hysterectomy? Yes or no, Aman?
I think so, ma'am.
You do. Manish?
No, ma'am.
No, ma'am. Okay. Very good. Qayyum?
No, ma'am, it's not hysterectomy.
No. Shabri?
No.
No. So the 3 people who said no, please tell Aman why it is not, hysterectomy. Come on, Shabri. Why is this not a hysterectomy? And if you say no, then you have to tell me from where this section has come. What is the way that this material has been collected? You said no, but now you have to tell me how it has been collected.
I think it is hysterectomy specimen because there is
Now you
myometry.
have changed your mind. It is a hysterectomy according to you, Shabri. Okay, Qayyum. Yes, Qayyum. Are you going to change your mind now as well? You said no. Now tell me, Qayyum, is this or is it not? What about you now, Manish? You also said no. So are you going to agree?
Yes.
You're going to agree that this is a hysterectomy, and Qayyum also agrees that it's a hysterectomy. Huh? You mean somebody took a section of, all of you have taken sections from the uterus, right? You have. Have you ever taken a jagged bit from the myometrium like this? In fact, the myometrium is the one that is nice and square sections you take, yes or no? Huh? So
No,
this
you don't
cannot
take
be.
this jagged type of bit.
You don't, because you take nice and square sections. So how did this become jagged like this? And you see the length of this section, and you have a little jagged bit over here. Do you see that jagged bit or not?
Yes, ma'am.
So how can that be a hysterectomy? This is what is called a hysteroscopic trans-cervical resection. They put the hysteroscope in and then they do something like a deep curettage. And this is the deep curettage from the endometrium. So they take out a bit of the myometrium and they take out, obviously, the entire endometrium, right from the surface down to the basal part of the endometrium and a portion of the myometrium. Okay, that's what you see over here. Next. Okay, so we do endometrial sampling in 3 ways. You do it as an office procedure in which you just put a thin little curette and you take a biopsy. That's what we call an endometrial biopsy. And we do it without cervical dilatation. When we put a curette in, the endometrium has to be curetted, the cervix has to be dilated. And that endometrial curetting cannot be done in the office or in the OPD. It has to be done in the operating room. And it should not contain this basal endometrium, or what we call basalis. It should not be removed. Why? Why should it not be removed? Do you ever see basalis in your curettage? The answer is, you should not see it. If you see it over there, the endometrium cannot regenerate because the endometrium regenerates from the basalis. And you will get a condition known as Asherman syndrome, where the endometrial walls become sticky because there is no endometrium to keep it apart, and that's a very difficult condition to treat. Now, hysteroscopic trans-cervical resection is what I just showed you a picture of. It's an operating room procedure. It's done under anesthesia. It is never performed if fertility is to be maintained. Why? Same reason, you do not want the basalis scraped, which in this case you are, okay? So it is done before a planned hysterectomy. If you want to do a hysterectomy, you want to find out what this endometrium looks like so that you can do that kind of thing. Now, this is the same endometrium that you're seeing over here. I placed it on this. Can any one of you take your color or whatever it is and show me where the basalis is, or the basal endometrium? Who's doing this? Yes, Qayyum, this is your to be. Can you take a color and mark? Can you mark it? Where is the basalis?
In this section,
Where is it? Is it there or not there?
not there, ma'am.
It's there. It's very much there. That is the basalis. And you notice this is a typical corkscrew endometrium that you see. Can you see this? This is what is a corkscrew endometrium. That is what we talk about your secretory phase endometrium. Okay, this is a secretory phase endometrium. That is basalis. Excellent. Now somebody wants to show me the next level. What's the next layer? More superficial layer. What is it called? What is
Spongiosum.
it called? Yes?
Spongiosum.
No, it's not spongiosum, please. What is it called?
Functionalis.
No, it's called functionalis. Because this is the portion of the endometrium on which estrogen and progesterone act. In the sense, of course, it acts on the basalis, but you see the effects on the functionalis. Okay. Have you finished all the levels of the endometrium now? Layers of the endometrium? Have we?
We haven't talked about the lining.
So there is another layer which is called the endometrial lining. Yes. So you have an endometrial lining, then you have the functionalis, which has all the glands and the stroma, and right at the bottom there is the basalis. Okay. So all of what you see in your normal curettage is taking place in the functionalis. Okay, and you should see endometrial lining epithelium. If you do not see endometrial lining epithelium, then you know that something has been done before, because the endometrial lining epithelium does not fall off by itself. Either a curettage has been done before, or there has been a lot of shedding of the endometrium if you don't see this lining endometrium in a hysterectomy. All right, next. So endometrium is physiological, or it is not. Physiological endometrium is prepubertal, cycling endometrium, pregnancy and lactation associated, and postmenopausal. And we should be able to identify all of these different phases of the endometrium right from from prepubertal to the end. And this, we never see very rarely do we see prepubertal endometrium, because nobody scrapes it, or you don't have hysterectomies that are done before puberty. But this is the menstrual cycle, and you have to understand the menstrual cycle, okay? And there's only one thing that you have to understand about it, and you can't forget it, and that is estrogen promotes proliferation, and progesterone promotes differentiation, okay? And what do we mean by promotes proliferation? Do you understand what estrogen is doing? And estrogen, of course, comes from where? Where does the estrogen come from? Where does estrogen come from? Does it come from the pituitary? Does it come from the adrenal? Does it come from where? Come on. Shabri, where does the estrogen come from? In this whole table, can you see where estrogen is likely to come from?
Granulosa.
Yes, the granulosa, where from the follicle.
Ovary.
Yeah, from the developing follicle. That's where the estrogen is coming from, and the estrogen comes from the developing follicle because that follicle is being stimulated. It is being stimulated by what? follicle stimulating
Follicle
hormone,
stimulating.
FSH. Okay, there it is. So FSH is stimulating the follicle secretes estrogen, there is a peak, and when there is an estrogen peak, there's a feedback which tells the pituitary to secrete luteinizing hormone, and you see that as soon as the estrogen reaches a certain peak, the pituitary secretes luteinizing hormone as a pulse. And you see this luteinizing hormone came as a pulse, and that pink thing over there, and then you have the luteinizing hormone has disappeared. Right. Okay. So you see then what's happening in the ovary, and you can see that what is happening over here in the ovary. You start with a follicle, with a small little ovum which has its little capsule of granulosa cells, and then there is a stimulation. You get the formation of a larger and larger follicle until that follicle ruptures, and then you get ovum, and you get ovulation, and then you get, what's this yellow thing called? The corpus luteum. Okay.
Corpus luteum.
Yes, and the corpus luteum secretes progesterone.
Progesterone.
Exactly. Now, what did I mean by estrogen promotes proliferation and progesterone promotes differentiation? What does it mean? What is this differentiation that I'm talking about? It's exactly what you saw, no, in the secretory phase. It has to secrete. The stroma has to become decidualized, or what you call pseudo-decidualization, and the whole endometrium has to become a place where, if there happens to be fertilization, that ovum can be, or the zygote can come and rest in that decidua. Okay, so that's the meaning of differentiation. And you know one thing and you must remember this, that no differentiation can occur if proliferation is going on. So if you want something to differentiate, proliferation has to be shut off. So remember this, estrogen promotes proliferation and progesterone promotes differentiation. And with that thing in mind, let us just go to the next thing, and you tell me here what phase of this is a cycling endometrium. Please tell me what phase of the endometrium this is. Yes, Kayum? What phase of the endometrium is this?
I'm not able to see.
Sorry?
I'm not able to see the board, man.
You can't see what?
The board, man.
You can't see the board. I'm sorry, you can't see anything?
No, ma'am. Just the pictures of all of us.
Can you see? You can't see the board. Oh, I'm sorry, but I could see.
You're not able to visualize the slide?
No, ma'am. I'm not able to.
None of you can?
I can, ma'am.
I can.
Who can? Shabri, can you see?
Yes, ma'am.
Shall I reconnect?
Who is asking, can you reconnect, Kayu?
No, ma'am.
Aman.
Aman.
You can reconnect then. Meanwhile,
Yeah,
others
but
will answer.
in the meantime, Shabri, can you tell me?
It's proliferative phase.
Proliferative phase. Okay. What about you, Aman? Is this the proliferative phase or the secretory phase? Do you agree with him? What is it, Aman?
Aman is
The
reconnected.
proliferative phase.
Okay. Kayum is saying proliferative phase. Very good. What about you, Monish?
Proliferative phase, ma'am.
Yeah. Why?
Ma'am, regularly placed glands and cellular stroma.
Okay. Kayum, why?
Ma'am, it's a compact stroma
Mm-hmm.
and glands.
I see. Okay. Shabri, why?
There is no subnuclear vacuoles.
Because there are no subnuclear vacuoles. How does anybody know that something is proliferating? How, if I asked you, just
Any
tell me
mi-
how you know that something is
Any
proliferating?
mitotic activity seen in
Can you see mitotic activity? Or you can't? What?
yes,
Yes or
ma'am.
no? You
Yes,
can't
ma'am.
see mitotic activity?
Yes, ma'am.
Oh, there is a huge amount of mitotic activity.
Yes, ma'am. It is present.
Yes, ma'am.
Yes or no?
Yes, ma'am.
And it just
Yes, ma'am.
the amount of mitotic activity that is being seen. Oops, 1 second. I can't. Everywhere you can see mitotic activity. Look at the amount of mitoses here. Look at the
Yes, ma'am.
mitoses over there. So why are you guys, talking about round glands and cellular stroma? The only way you will know whether there is proliferation is by, or no proliferation as the case may be, by looking for mitotic activity. Have you ever looked for mitotic activity in the endometrium? Shabri? Yes or no? No. Aman? Yes or no?
Yes, ma'am. Look for the mitotic activity.
You do?
If it is
All right,
present or
okay.
not.
Excellent. Qayyum, have you looked or you have never looked?
Ma'am?
Have you ever looked for mitotic activity in the endometrium? Yes or no?
Yes, ma'am.
Oh, you have. Or you're seeing it. Yeah, what about you, Manish? Have you ever
Yes, ma'am.
looked? Then why
Yes,
can you
ma'am.
not tell me that this is the proliferative phase because there is mitotic activity? That's the only way that you will know that the endometrium is proliferating, and that is if you see mitotic activity. There's no other way. And that mitotic activity will be seen in the glands. It will also be seen in the stroma. But you can't see it so well in the stroma. Why? Why? And we have to finish soon. Why can't you see it in the stroma? Because the stroma is so small. You can't see mitosis because the stroma is so blue. It's full of, the nuclei are so blue. So you look for it in the glands and look at the amount of mitotic activity that you see. And if you really want to check it out, look at the amount of mitotic. This is the mid one, that is the labeling index, and look at the stroma. It's full. That is the only way that you will know that there is proliferation. And when there is proliferation, what is the inference that you make from that? That estrogen is acting on the endometrium. So you see the mitotic activity, you know that there is proliferation, and therefore estrogen has acted on this endometrium. And if you go now to the next thing, you see this? This is tortuosity. Spiral. It's like a snake. That is what is there. And look carefully. Do you see any mitotic activity?
No, ma'am.
The answer is
No,
no.
ma'am.
There is no mitotic activity. And I told you that progesterone, if it has to act on an endometrium and differentiate it, what will the first thing that will happen?
Estrogen has to be.
Absolutely. Not estrogen will have to disappear. Estrogen never disappears. It's proliferation that is shut off. So progesterone shuts off the proliferation so that the endometrium can differentiate. And this is, yes, and this is something that you guys have to understand. You don't have to look here, there, everywhere. Just look, and you look at the labeling index. The labeling index is somewhat high when you are at an early secretory phase where you see the subnuclear vacuoles. But by the time you reach the late secretory phase, there's hardly any proliferation at all. So that's all that you actually have to remember about the endometrium. I have to look for mitotic activity. If there is mitotic activity, there is estrogen hanging about over here. Yes. Otherwise, if there is no mitotic activity, the estrogen levels are extremely low in this. All right, now let's do this. This is a menstrual endometrium. I don't think we need to go into that in great detail. This is decidualized, and there's some Arya-Stellar reaction. So this is a pregnancy-associated changes. And now we come to how do you report on an endometrium? Okay. If it is scanty, you say it is scanty. If it is premenopausal, you have to, it's a cycling endometrium, so you have to talk about the phase. But the way that I look at an endometrium is, please look at the endometrium from the view of its hormonal, what hormones are acting on this endometrium. All right, if you see progesterone that is acting on that endometrium, check whether that progesterone is acting on the glands or it is acting on the stroma. If it is acting on the glands, then you should see the glands becoming corkscrew and the stroma showing decidualization. But if it is acting only on the stroma, then there's something happening with the glands where that progesterone is unable to act. And we will come to that in 1 second, okay? Yeah, now I want everybody, those of you who are still remaining over here, here is an endometrium. Now please answer this question. Is this low estrogen? Is it high estrogen? Is it progesterone? Or is this an endometrium where the pill has acted? Yes, Shabri, what is this?
I think low estrogen.
Low estrogen, very good. It could also be a pill endometrium. I don't know what the rest of the people said, but this is a low estrogen endometrium. And why did you say it is low estrogen? Shabri? No? Why?
Madam, it is in the endometrium is in the proliferative phase.
In the proliferative phase. If it was in the proliferative phase, it should be high estrogen. So
Very low
The glands are not showing
very low mitotic
mitotic activity is not seen.
not seen.
I see.
And
You can actually, here you're looking for mitotic activity. You can
and the glands, the lining of the glands are also not, stratification is not observed in the glands lining.
Okay. Yes, Monish?
Glands are regular, stroma is not too compact, no mitotic.
Here is basalis. No, at the bottom is basalis. You can see the can you see this? This is the myometrium. Yes. So this has to be basalis, and this is the superficial. So how is this endometrium? Is this thick? Is this thick or thin endometrium? Shabri, is it thick or is it thin, this endometrium?
It is thin endometrium.
So the basalis is occupying almost half of this endometrium. So obviously this is a low estrogen endometrium. Okay. All right. Do you think this is a hysterectomy or this is a transcervical resection that we saw? That means one or the other, or it is a curettage? What is this? Come on, tell me. Aman, hysterectomy or curettage? Hysterectomy or curettage?
Hysterectomy.
Monish?
Hysterectomy, sir.
Yes, it is a hysterectomy. It can't be a curettage. You can't get this such a thick part of the myometrium in a curettage. What did most people say, Shweta?
For the question with 40% have answered OC pill, the upper question.
All right, that's also acceptable. Yeah.
And 32% have answered as progesterone, 17% low estrogen, and 10% high estrogen.
There is no progesterone in this at all, because if there was progesterone, you would have had decidualization or a corkscrew endometrium. So this is not progesterone at all. Okay, so this is a hysterectomy, that's fine. Let's ask the next question. Do you think this is an 8-year-old, this is a 25-year-old, or this is a 60-year-old? Shabri? You said low estrogen, right? So now tell me, is it 8 years old, 25 years, 60 years old? What? Huh? Come on now. I'm getting a bit of an echo. Aman?
Yes, ma'am. I think it's a 60-year-old.
60-year-old. Very good. Qayyum?
Ma'am, it's a 60-year-old.
60-year-old. Very good. Munish?
I think it is 80-year-old.
You think it's 80-year-old? Achha, so something that I haven't even put up over here. Okay, good. Yes, it is an atrophic. This is an atrophic endometrium. There's no doubt about
Atrophy.
that. Yes,
Atrophic
if
endometrium.
somebody thought that it was a pill endometrium, then the patient could have been 25 years old. Okay, but if you think it is an atrophic endometrium, when you have an elderly person, the line between the myometrium and the endometrium is not sharp. That is another thing that we need to keep in mind. Okay, I need to get rid of this, and I can't find. Can you clear it for me, Shweta? Because their pictures are on that place, so I can't. Okay, I've cleared it. Good. Now you tell me, is this a cycling endometrium or a non-cycling endometrium? What do you think? Shabri, you're cycling or non-cycling?
Non-cyclic.
Non-cycling. Aman?
It's a non-cycling endometrium.
Non-cycling. Do you know what we mean by cycling endometrium? It has to be during the reproductive age group. Qayyum? Cycling or non-cycling?
I'm cycling endometrium.
Cycling endometrium, yes. Munish?
Non-cycling endometrium.
Non-cycling endometrium. What is the first thing that you should look when you're looking at an endometrium? We just discussed that, right? What is the first thing you should look for?
Then just to interrupt, from audience, it is a tie response, 50% cycling and 50% non-cycling.
Yeah, good. This is good. What is the first thing that you look for when you look at an endometrium? We already went through this. What do you look?
Mitotic.
Huh? Mitotic figure.
Mitotic activity.
So is there mitotic activity or not? Of course there is mitotic activity. You can see within
Ma'am, there is the glands.
Absolutely. So there is mitotic activity in the glands. So what does that tell you?
But it is proliferative type.
That estrogen
Proliferative.
has
Estrogen.
acted on this endometrium. All right? And therefore, it is likely that this is the proliferative phase. Yeah, you can't see the basalis over here. The basalis is towards the left side. You can see the superficial endometrium on top. Yes? You can see there where the superficial endometrium is, right on top. Here's the superficial endometrium. And you can see all these nice round glands. There is no branching, nothing. And you can see mitoses. So this is a proliferative phase endometrium. Oh, sorry, I went next. So this is a cycling endometrium. Okay. Now let's go to the next question. Low estrogen, high estrogen, progesterone, or OC pill endometrium?
High estrogen.
So who said high estrogen?
And
Now it's so easy, right? It's easy. If you pay attention to this mitotic activity, you shouldn't have any problem at all. But there is estrogen, yes. But what should the high estrogen look like? We know that there is. This is a resting endometrium. Okay, it's cycling, but it is resting. So if you had said high estrogen, okay, I wouldn't have, but there is estrogen as long as you are able to make that out. Okay, now you tell me, low estrogen, high progesterone, or OC pill endometrium?
Ma'am, before this, the audience had answered 75% had answered high estrogen.
Okay, that's fine. It's as long as they knew there was estrogen, and it's not bad. Okay. Now come on, Monish. What is there?
Low estrogen.
Low estrogen. Well, Shabri,
Low estrogen.
low estrogen. Tayyum,
I'm low estrogen.
low estrogen. Okay. And Aman,
And low estrogen.
low estrogen. What is the stroma like?
Stroma appears to be
What? No, it appears to be what? Decidualized, right? It is decidualized. So they cannot be low estrogen, high estrogen. It has to be
high progesterone.
high progesterone. So what did the audience answer?
And 31% have answered OC pill endometrium, 43% low estrogen, 24% progesterone, and 1% high estrogen.
Yeah, it is truly decidualized. When decidualization occurs, the glands become very small and almost they look as if they're atrophic, but it's not atrophic. This is a high progesterone endometrium. The question is it truly decidualized or is it iatrogenic? There is progesterone and there's a high amount of progesterone in this thing. Now you tell me this. Qayyum, what do you think? Aman,
I'm decidualized.
you think it's decidualized. Aman,
I think it's an iatrogenic.
decidualized? Okay. Shabri,
Iatrogenic.
iatrogenic, yes.
Hydrogenic one.
Iatrogenic, yes. Well, it is iatrogenic. I told you, no, if you don't get progesterone that is acting on the glands, then you should worry about whether this is not iatrogenic, and this is an iatrogenically progestationalized endometrium. Okay? All right, good. Now you tell me, low estrogen, high estrogen, progesterone, or OC pill? Come on, Shabri.
High estrogen.
High estrogen.
Estrogen.
Yes, Aman. Somebody else said high estrogen. Munish, did you say?
No, ma'am.
Oh, Qayyum. What did Qayyum said high estrogen? Very good. Then, Aman,
High estrogen.
high estrogen. Okay. And what about you, Munish? It is high estrogen. Huh? It cannot be high. It cannot be progesterone. And you see, this is a disordered. The glands are branching, and you have seen it before. So this is disordered proliferation. It has to be high estrogen. What is the audience saying?
45% have answered as progesterone, 37% as high estrogen, and OC pill endometrium 15 and 2% low.
All right. Anyway, it is high estrogen. You just have to look and see, is this estrogen acting or not acting? Now, what would you say? Are these anovulatory cycles? Obviously, no. There's no progesterone. So it's an anovulatory cycle. 28 days, 36 days, or 60 days? In other words, what I'm asking is, how long has the estrogen been acting on this endometrium? The normal cycle is 28 days. So is this 36 days, 28 days, or 60 days? Monish? So how much proliferation do you think there is? If there was a lot of proliferation, how much stroma would there be? The glands would be proliferating and the stroma would be Less, no?
Yes.
So what do you think this is? 28, 36 or 60? You have to eliminate one. So which one are you?
Ma'am, I'll eliminate the 61.
60. Excellent. And it's certainly not 28.
Yes, ma'am.
Okay.
Right.
Yeah. Because nobody would go and curate out an endometrium for a 28-day cycle, right? There is a problem, otherwise this patient wouldn't have come. So it is 36 days. That's what this is. Okay, very
The
good.
audience majority have answered 36 days, 48%.
Very good. Now, low estrogen, high estrogen, progesterone, same thing. Come on. This is easy.
High estrogen.
High estrogen, everybody agrees?
High estrogen.
Yes, there's no doubt about this. No, you can see that it has to be high estrogen. Very good. Now choose 28, 36, 60 plus.
It appears to be 60 plus, ma'am. Because it's
So this is 60 plus. See how easy it is if you only pay attention to something simple, and that is, what is that simple? It's an unopposed estrogen. You can see that. You can call it atypical hyperplasia.
Estrogen.
Yeah, whatever. But it's estrogen that is acting on this endometrium. Okay? Now, what do you think is the cause of this? Oh goodness, I'm getting an echo. Of this anovulatory cycle for 60 days. Do you think this is a 36-year-old with a PCOD? You know what is PCOD? Polycystic ovary. Yes. 56-year-old on HRT, that means hormone replacement therapy. 48-year-old who is obese, or all of the above? Yes? We know it's high estrogen. Okay? So can a patient with PCOD have high estrogen? Yes or no? What is PCOD? Anybody would like to say what is PCOD? Polycystic ovarian disease. Do you know where estrogen comes from? From where does estrogen come? We just went through that. No, where does estrogen come from? From granular
cells of ovary.
In the ovary, I agree. And granulosa cells are found where? In the ovary. Where are they found in the ovary?
In the developing follicles.
In the developing follicles. Right?
Developing follicles.
So what is this polycystic ovarian disease? So what are those cystic?
They are the follicles.
They are the follicles, no?
Yes,
They are follicles which are not, there is no ovulation taking place. The follicles are just getting, cystic. There is a whole lot of FSH that is stimulating this ovary, and it's producing a lot of estrogen, but there is no luteinizing hormone at all. So these are all unruptured follicles. There is an accumulation of these developing follicles. And what are the follicles making? They're making estrogen. Because all estrogen comes from granulosa cells, and granulosa cells are lining the follicles, and therefore if you have lots of follicles, you're going to get lots of estrogen. So yes, 36-year-old with PCOD can get it. Can you get a 56-year-old on HRT?
Yes, ma'am. Yes.
If for some reason this HRT contains a lot of estrogen, that's what can happen. What about a 48-year-old who's obese?
Yes, ma'am. We can get
because why? Because the fat is making estrogen. No, because the fat is making estrogen. Okay? Yeah. There are 3 places from which estrogen gets secreted. One is the
converted.
Yeah, the other one is fat. And the 3 different hormones. The estrogen that is produced by the ovary is called estradiol. What is produced from the fat is known as estradiol. estrone, and then there is a third place from which you get estrogen, and that is from the placenta. And what is that estrogen called? It's called estriol. Okay, the most powerful of the estrogens is estradiol. The next most powerful is estriol, that means the activity wise, and the least powerful is estrone. But if you're very obese, and there is a huge amount of estrone coming from your ovaries, estradiol, and you're also obese, you're getting a double whammy of estrogen. And therefore, what is the answer to this question?
All of the above.
All of the above. Excellent. Right. Good.
Then the
So
audience also
I'll
has
cut this and we'll do it some other time. Yeah, sorry.
the
What
audience also have answered perfectly. Like 50% of audience have answered all of the above,
Excellent.
and 20% have answered 36
Okay.
with PCOD and 56 with.
I think we have had a very long session. I hope you've understood something about the common things that we see. Yes. And I think there's one person left who hasn't answered. Who's that? Shabri, I suppose. No, he hasn't had a case. We can't do it now, Shweta. I think if we,
Yes,
it
ma'am.
will be too tiring. And there is a lot to actually discuss in this. So
Yes,
we'll think of some alternative date. Maybe when would you like to do it on a Saturday?
Wednesday and Monday both are free, ma'am.
Sorry.
This Wednesday and coming Monday both are free.
Okay. So can we do it on this Wednesday then?
Yes, ma'am.
So we'll finish this on Wednesday. Are you guys okay to come on Wednesday?
Yeah, sure.
Yes, ma'am.
All right. And Shabri, you're the only one who hasn't answered right. I think one case one was done by who? Kayu? No, was
Aman.
done by Aman. 2 was done by Kayu. 3 was done by Monish. Right? So now Shabri is left. So now you know which case is coming to you, Shabri, so you better prepare.
Okay, okay, ma'am.
All right, thank you, guys. I hope I didn't bore you to death, that you have understood something about the cervix, you have understood something about the endometrium and what is decidual. Okay, good.
It was very true.
Sorry? What did you say, Shabri?
No, ma'am.
Oh, to somebody else. Okay.
Okay. Thank you. I hope you people enjoyed our webinar, and we have upcoming future slide seminars, and they will be held on first and third Mondays of every month. And we request all HODs to recommend students, especially final year students, and to recommend, they can send us email on this email address that has been given here. And the upcoming slide seminar is by consultants from AIIMS, and that is based on hematology, peripheral blood smear by Dr. Ganesh and Dr. Jasmita Das, and we are really looking forward for it. And that is on September 21st. And tomorrow we have a talk on PCR principles, types, and current application that will be delivered by Dr. Arpan Mehta, and the chairperson for that is Dr. Nikhil Patkar. So you, for keeping posted, you can join our Telegram group. You can scan the QR code that is given here, and you can join. And all the webinars, upcoming webinars, all the updates are given in this link provided here. Thank you, everyone.
Thank you very much, Shweta. I kept you very long, all of you. It's I enjoy teaching, but I hope that you guys don't get too overburdened. So we'll do the next one on Wednesday. Yes.
Sure.
Okay. Good.
Okay, ma'am.
Thank you.
Bye.
very much.
Thank you very much. Thank you, Shweta, and thanks to all of the whole team who has prepared this. And I must tell you that Shweta has really done yeoman service, because I had a PowerPoint presentation which had a lot of of these animations. And when you're presenting it on a whiteboard, animation doesn't work, or when all of you are in the room. And that's she has taken all the trouble to convert an animation thing into a PowerPoint that is suitable for this. Thank you so much, Shweta. I can't thank you enough. Okay.
Thank you,
All
ma'am.
right.
Good night.
Okay. Bye. Good night.
Bye.
Thank you, ma'am. Thank you.
Okay. Bye.
Thank you, ma'am. Good night, ma'am.
Good
Bye, ma'am.
night. Good night to all
Good
of
night.
you.
Good night.
Good night.